Welcome to the 55th Stikeman Visiting Professorship in Cardiac and Thoracic Surgery. This is the longest running visiting professorship in all of McGill, and it's an absolute pleasure to invite you all and welcome you all to this year's event. We're lucky to have a member of the Stikeman family join us, who've been really supporting this important event and most important event in our calendar for the past 57 years. But due to the pandemic, this is our 55th Stikeman Visiting Professorship. We have an absolute pleasure to invite many of our alumni back. We celebrate our research trainees and our graduating fellows, and we bring a important icon in thoracic surgery or cardiac surgery every year in order to sort of set the tone. This year is no different. We're absolutely pleased to welcome David Jones to McGill from the Memorial Sloan Kettering Cancer Center. Dave Jones is a man of the South. He's originally from, did his undergrad, med school, general surgery training in University of West Virginia, his cardiac and thoracic training at the University of North Carolina in Chapel Hill. He went on to have a career, illustrious career in academic thoracic surgery at University of Virginia. And in 2013, he was recruited to the Memorial Sloan Kettering Cancer Center in New York, where he's currently the professor and chair of thoracic surgery at that institution, as well as the Fiona and Stanley Druckenmiller Chair of Lung Cancer Research. Dr. Jones is truly an icon in thoracic oncology. He is the current president of the AATS, or American Association of Thoracic Surgery. That's our sort of central society, which all of us cardiac and thoracic and congenital all meet. He is a incredible clinician, educator, and scientist. He has over 450 publications, and really has led the the field in lung cancer surgery. It is our absolute pleasure to welcome Dr. Jones as our 55th Stikeman Visiting Professor to McGill. Dr. Jones.
Just like to thank Lorenzo and faculty here at McGill for the kind invitation to serve as the 55th annual Stikeman professor. It's my first time to Montreal, and we had a wonderful dinner last night, and I'm very much looking forward to the day ahead to spend time with you and learn from you as well. Today, we're going to talk about the thoracic surgery oncology trials. Kind of where are they now? And as you can sense, we're not doing as good a job as we possibly could. So how do we move them forward? Here are my disclosures, some of which are relevant to the presentation today. So I think it's important to remember that surgeons have always played an important role in clinical trials. This is the first documented clinical trial, and it was made by James Lind, who was a Scottish surgeon. And he made the observation that scurvy was causing more deaths of the sailors in the British Navy than being killed by the Spanish and French ships. And he hypothesized actually that it was a lack of fruits, meaning i.e. vitamin C, that was contributing to this. So he did a controlled trial where he gave half of his sailors oranges and lemons, and the other half didn't get any. And of course, proved that it was scurvy. He didn't know it was vitamin C. That wasn't discovered until around 1920 or so. But the point is that surgeons were very much involved in clinical trials. If you look about clinical trials in North America, the sine qua non of the trials was really the lung cancer study group. And that all generated in the early 1970s when it looked like there was very good evidence that cisplatin-based chemotherapy would be helpful in an adjuvant setting in solid tumors. And there was really no mechanism in this to look at the increasing number of lung cancer patients and could we offer them some type of systemic therapy. And Vince DeVita, at the time NCI director, agreed to form a new clinical trial group called the Lung Cancer Study Group. And there was a contractual arrangement between the NCI and CTEP and selected institutions. I won't get into all of that. But in 1984, that moved to a request for applications and becoming an NCI cooperative group member. So the Lung Cancer Study Group was the first. They had a site visit in 1986, and tragically, 3 years later, a repeat site visit recommended closure of the Lung Cancer Study Group, and we can get into that at another time. But here were the Lung Cancer Study Group trials during its 12 to 13-year existence. And you can see even then it was multimodality. Surgery plus immunotherapy, actually, surgery plus chemo, 10 trials, interpleural chemo, 2 trials. And all in all, there were 22 trials that were put forward. 91% had surgery as a component of the care plan in those clinical trials. They accrued over 4,000 patients, 7 trials with surgery plus RT, 10 trials of surgery plus chemo. Over 100 publications came out of the Lung Cancer Study Group, and they placed more patients on protocol during that time than all of the other cooperative groups combined. So if there's any message that should be taken here is that surgeons working collaboratively with their colleagues can accrue patients to clinical trials. This is probably one of the seminal papers by a Canadian, Bob Ginsberg, and the Lung Cancer Study Group looking at the role of lobectomy versus a segmentectomy or wedge resection for early stage node negative non-small cell lung cancer. This trial started in 1982. It completed accrual in 88 and made the observation that we won't get into it too much, that a lobectomy was superior in terms of local regional control relative to a sub-lobar resection. And that set the stage for lobectomy being the standard of care up until more recently, as we'll see later. So if you look at the prior NCI clinical trials unit infrastructure in the United States, you can see what it used to be like after the Lung Cancer Study Group was disbanded. And you'll notice this group called the ACOSOG, which was the American College of Surgeons Oncology Group. And this was where the thoracic surgeons and general surgeons as well, and surgical oncologists, really collaborated and worked to do clinical trials. This was led by Sam Wells, who at the time was at Washington University in St. Louis. Again, formed in 1997, 8 specialties. So you can imagine breast, GI, thoracic, et cetera. This is the first time that surgeons were really, again, back in the driver's seat for NCI-sponsored surgical oncology trials. And initially, it was just surgeons only, but then again, like all good cancer trials, pathologists, radiologists, and our other colleagues began to participate. There was a large tissue biorepository, so important, banking of tissue. Sam knew that, and it still exists and is being used today as well at Washington University. There's also a T32 training grant. We'll talk about the importance of training the next generation of clinical trialists, but that is, they had 4 house staff every year would get a master's degree for 2 years and then get a master's degree. And then they first began to also support the correlative studies that are, again, so important in our trials today. And here were some of the early thoracic surgery clinical trials. And Valerie Rush was the initial PI or head of the thoracic surgery arm. Bill Putnam became the chair of that. And I was fortunate as a younger faculty member to head up the correlative science studies, and really gave me my first glimpse of what trials could look like. And here are some of the 5 trials that came out of the thoracic surgery group. I'm not going to go through all of them, but some were published in the Journal of Thoracic and Cardiovascular Surgery, but a couple were published in Journal of Clinical Oncology. So actually a very good publication record and a couple were randomized controlled trials as well. But it wasn't just thoracic. These were some of the papers that were coming out of ACOSOG that were also really important. I mentioned mediastinal node sampling versus dissection for early stage, brachytherapy, local recurrence rates. This was a phase 3 randomized trial published in JCO. But also in breast, this is the Z0011 Alliance trial that still it was practice changing then and it's practice specific now. And then hypothermic isolated limb perfusion. I'm just going to go through these, but all very high impact, practice changing publications published in important and high impact journals. So you would think that everything was going well in the clinical trial program run through the NCI through ACOSOG, but there were some concerns. And at the time, the NCI director charged the Institute of Medicine in 2007 to deal with some of these challenges. And those challenges were really this iterative layer of oversight that was taking too long to open up trials. It was grossly inefficient. The average time to open a trial coming through the NCI clinical trials program was at least 2 years. And since 2002, there had been no real change in funding. So these were the goals to go ahead and increase the speed and efficacy of the trial design, incorporate innovative science and trial designs, prioritize trials, and incentivize patients and physician participation. And this is what the IOM came back to the NCI with this report and said this needs to happen. So that report was finalized in 2010, and they reduced from 10 to 4 adult cancer cooperative groups, including the Canadian group. And this allowed them to consolidate resources so they could afford to do 4 and hopefully do 4 better. There was a real charge to collaborate with industry and the private sector. And unfortunately, that really has not happened. And I can just share with you that the National Clinical Trials Network budget is $171 million, or 2.3% of the entire NCI budget, which is $7 billion. And that number has not really changed over the years. So unfortunately, the NCI, despite the IOM report, has not put the money that's needed in order to really increase clinical trials for surgery, surgical oncology. So this is the current NCI trials network. And you can see ACOSOG is gone. There is no surgeon-specific group. Surgeons are embedded in some of these groups. So particularly, I would say in SWOG and the Alliance group, and a lesser degree in ECOG and Akron. Interestingly, there still is a lot of radiation oncology in our RTOG. So in preparation for this talk and kind of seeing what's going on, what's the landscape of lung cancer trials through the groups involved in the NCI Cooperative Center today. SWOG, there are 7 trials open that deal with lung cancer. 0 involve early stage disease or surgery. The NRG Oncology, I mentioned RTOG, 5 trials open, none for surgery. The Alliance Group, 8 trials open, none involve early stage disease or surgery. There's plenty of advanced stage disease, but none for early stage. ECOG or Akron, 1 is open. That's the adjuvant crizotinib for ALK fusion positive tumors. That's for stage 1B to stage 3. With the current accrual rates, that trial will close in 2036. I think that just tells you the problem here at hand. If you go on and look at the Canadian Clinical Trials Network, from my read of it, 5 trials open, 2 neoadjuvant kind of TKI investigator-initiated trials involving surgery. The Hooser Cancer Research Group, another big cancer group in North America, 6 trials open, 1 adjuvant IO. So really 37 clinical trials now in North America that are open involving lung cancer. Only 4 involve surgery. So it's it's a very different landscape now than it was back for the lung cancer study group. So what's gone on in thoracic oncology surgery? What are the randomized controlled trials, maybe over the last decade? But this was a paper in the New England Journal of Medicine Evidence, the online journal, from Eric Lim, looking at thoracoscopy or open lobectomy. And the authors found that, at 5 weeks, the thoracoscopic group had less pain and they did better. Not really practice changing, but that was a randomized controlled trial. A couple randomized controlled trials looking again at sublobar versus lobe. This is 40 years later. We're still looking at the same issue and showing that actually a segmentectomy in this situation for these early stage tumors was not inferior and in fact superior to a lobectomy for small tumors. Nasser Al-Torki published in the New England Journal of Medicine last year, that in fact, a wedge resection or a sublobar was not inferior to a lobectomy. So both now saying, in contrast to Ginsburg's study, that for selected tumors, you may be able to do a sublobar resection and have the same thing. But pretty pedestrian, I would say. It's some ways. Yes, it's moving the field forward a little bit, but it's not what we would hope in terms of making practice changes. So here are the early stage non-small cell lung cancer randomized controlled trials that are industry sponsored over the last decade. And you know this because McGill has had very good representation with John Spicer and others. And we've also had Moshe on some of these as well. But this was the neoadjuvant nivolumab plus chemo trial that was published in 2022. The perioperative durvalumab trial, again, neoadjuvant, then surgery, and then adjuvant pembro at the or durva at the end. Here's the keynote trial here, the perioperative pembrolizumab, same story. These are practice-changing clinical trials. If you move away from IO, you can look at TKI. This is adjuvant osimertinib in resected EGFR tumors. Again, practice-changing, very positive impact on overall survival and disease-free survival. Adjuvant trials now looking at adjuvant atezolizumab. Again, this is what's been going on, but they've been sponsored by industry. So if we think about where have all the surgical oncology trials gone, they've really gone to industry. And what about future surgical oncology clinical trials? I think probably they're going to be industry and they're going to be international, and I'll get into that in just a minute. What about the investigator-initiated trials? Probably major academic centers like McGill can probably pull these off, but it's still going to be relationships that individual surgeons and academicians are going to need to partner with industry frequently. And that's all because to run a clinical trial now is just so exorbitantly expensive. So at MSKCC, our surgery oncology trials, our trial budget for the Department of Surgery is about $9 million annually. We fund that through 100% for these people, the clinical research managers and supervisors, about $1.6 million. We fund that through the IDC, institutional IDC. All the other clinical research staff, we fund through either grants, industry, or philanthropy. You can see the number of trials that are open, those that are therapeutic or diagnostic, and this is across the entire Department of Surgery. So that would be, hepatobiliary, thoracic, breast, urology, et cetera. For thoracic surgery alone, we have 20 trials open, 5 are therapeutic, 8 are diagnostic or correlative studies. And we have 15 clinical research staff that help run these trials. So you can get a sense that it's extraordinarily expensive, and an institution has to be behind you in order to do this as well. So if you look about what's changed in terms of published randomized controlled trials, when you look at a couple key sites like breast, lung cancer, and colorectal, I can just tell you that what's changed over the past from 1995 now up to 2020, targeted therapy was 4% in that first decade. Looking there to your left, it's now 73%. So either targeted therapy or some type of immunotherapy is really how that's changed in terms of the randomized controlled trials. Our endpoints have changed. We don't look at overall survival so much anymore. We look a lot more at progression-free survival. So now progression-free survival is the most common primary endpoint. And almost 90% of all randomized controlled trials in these diseases, breast, lung cancer, and colorectal, are being funded by industry currently. And this just shows the funding of the randomized controlled trials over the past, 45, almost 50 years. Again, the blue line, overall survival, that's no longer the primary endpoint in many of the trials. Progression-free survival is changing. Around 2000, it began to change. And you can see that over 90% of trials are now funded solely by industry. So what's the problem here? The problem is that when everybody sits down at the table to generate the next clinical trial and they get input, we have a lot of people there. We have a medical oncologist, we have our industry partners. There's always a radiation oncologist, patient advocacy, so important. Maybe a regulatory expert, clearly one or more medical oncologists, a statistician, but the surgeons have been, I would say, largely absent. That's only begun to change over the last 5 to 8 years, I would say. So I looked at this. I was an associate editor for JTCVS for many years, and I noticed that we were not getting many clinical trials that were being published in the journal, and I did just a very brief editorial for the journal where I looked in 1 year at just the surgery journals. I didn't even look at the New England Journal of Medicine or Lancet or anything like that. And there were 295 overall publications. This is not just for oncology, it's anything. It could be for hyperhidrosis or whatever. 7 prospective clinical trials, 5 randomized controlled trials across 3 journals, the JTCVS, the European Journal, and the Annals of Thoracic Surgery. So that in total over a year, we had 4% of what we were publishing as surgeons were clinical trials, which is pretty bad. So what are the barriers to getting surgeons more involved in clinical trials? Well, there aren't a lot of opportunities to be educated to how to do clinical trials correctly, and therefore few role models. You know, if you look to the federal government, there's no great cooperative group to run surgeon-led trials through the National Clinical Trial Network. The trial infrastructure is extraordinarily expensive. We've seen that. It's hugely expensive. You know, if you're going to make an impact, you're going to need to partner with your medical and radiation oncologists because all of the therapies now are multimodality. They involve targeted checkpoint inhibitors. We're looking at ctDNA for MRD. We're looking at patient-reported outcomes. There's also been surgeons have not had a seat, as I said, with big pharma. They have not built relationships. It's been more relationships with Medtronic or Ethicon or staplers or this or that. There's very little incentive for surgeons at your own institution to participate in clinical trials. I mean, is that part of your compensation? Is that part of what you're expected to do? I would say oftentimes it's not well articulated that that's the case. And, you know, if you're a clinical surgeon, you're operating and you've got a lot of cases to do and you have to take care of patients. So do you have bandwidth to really get involved with this clinical trial business? So we need some solutions. So I'm going to share with you some of the solutions that we are doing within the AATS and within Memorial and within a group that we've formed about 6 or 7 years ago. But I think one of the biggest things we can do is put some effort into generating the next or educating the next generation of surgeon trialists. So we have this clinical trials methods course that we run through the AATS, and it started in 2014. It's a 3-day kind of full-time immersion. And you bring a partially written clinical trial and you spend 3 days, and literally they start at 6:30 and they end at 9:30 at night. And at the end of the day, or at the end of the 3-day session, you pretty much have a clinical trial written, and you get a lot of feedback from other people who are there. We've had about 106 attendees. It's been held every other year. We skipped 2020 because of COVID. And it's actually been pretty successful. There's a manuscript that's going to be coming out looking at the metrics of success. But surprisingly, when I looked at the American College of Surgeons, Society of Surgical Oncology, there's no such similar program. If you remember back to the lung cancer study group, and also ACOSOG, there were T32 opportunities to train these residents, but we don't have those types of things. So this is at least one effort to do some teaching and generation of new trialists. So it was clear to me that thoracic surgeons were not involved. There are a lot of surgical oncology questions that need to be answered. Not everyone's going to be cured by chemotherapy and radiation. Surgery has a very important role in the care of these patients. There is no enthusiasm if you talk to any of the directors of the NCI, including the current director, to form a new cooperative group that's going to be led by surgeons. It's not going to happen. They don't have the money and they don't have the interest in doing that. And the 2 points I made earlier about accruing patients to trials, I think remains important. So in 2017, we formed the Thoracic Surgery Oncology Group, and this was to try to reinvigorate and build a network of North American thoracic surgery clinical trials to help our patients. And so this is definitely multidisciplinary. It was formed in 2017. It was a joint effort between the AATS with MSK serving as the coordinating center. And we didn't know how this was going to go. It's clearly a grassroots effort. We didn't have any serious funding except for what Memorial was willing to pony up and what the AATS was willing to support. So we started small. We had 9 sites, and you can see the sites here. The asterisks, Brigham and Women, Duke, MD Anderson, Sloan Kettering. We had representation from those institutions to serve as an executive committee to give it some structure. And this is kind of the timeline. We had our first meeting in June at Logan Airport in Boston, and chose the sites. We then had an RFP for the trials. We met in Boston, as I mentioned. We selected 3 trials, and then we began to open up membership to others in 2018, and another RFA, more requests for proposals. We began to add sites. I'll go through that. And this is just kind of us working here at meetings in Chicago in 2020. This was about 10 days before COVID hit, and we were all just sitting around and had no clue what was going to happen. In 2023, this was right before the International Thoracic Surgery Oncology Summit, or the ITSOS meeting that we hold in New York every year. And I think the biggest thing that we did along with that is we began to have these panels with industry at the meeting in New York. And so this is in 22 and 23, we had these roundtables and really began to talk with industry about what role surgeons could play and should play in designing and participating, serving on steering committees for trials, et cetera. And to my knowledge, it was the first effort by thoracic surgeons to really sit down and talk about building relationships as a society with pharma. So what are the current TSOG clinical trials? So this is what we've done here. This is a perioperative trial looking at circulating tumor DNA in any patient undergoing neoadjuvant therapy. So before treatment, after neoadjuvant, and then after resection. So 3 blood draws, 100 patients, and that trial is now finished. And all the blood is undergoing analysis at Foresight. We had an active surveillance trial looking at how you manage multifocal ground glass opacities. Jim Wong. Mar Antonoff did a great job putting together a multimodality management in risk stratified patients with lung-limited metastatic colorectal cancer. We learned some things here. It was probably a little early for that level of complexity of a trial, and we did not meet accrual there and ultimately had to close that trial. The next 2 trials are actually related to R01 grants to these investigators. That we actually told them we would help them, we would support the trial, and it clearly helped them get their R01s funded. And so we've got a trial looking at a biomarker for malignant pleural mesothelioma run by Harvey Pass at NYU. Benj Kozauer is running a trial looking at SBRT and versus surgery and patient-reported outcomes. The surgery arm is complete, and we're just now completing the SBRT arm. And then we partnered with the LCMC4. Scott Swanson's leading this effort, looking at obviously the Nautica and the actionable drivers in early stage lung cancer, a big screening study of over 1,000 patients. So this is what we've done since then. Here are the sites that we've opened. There are now 35 TSOG sites across North America. This includes 4 in Canada. And you can see the institutions here, including McGill joining us last year. And I think this has taken a huge effort on our part at Memorial from a legal perspective to get all of these sites signed and delivered, and dealing with their attorneys at all of these sites to make sure that everything is appropriate. And I give a shout out to the group there. This is just the similar slide again, the TSOG 101 ctDNA completed, the GGO trial, 337 patients completed. We did not complete the colorectal mets, and then you can look at the accruals for TSOG 104 and 105. So I think really an effort from at a grassroots level getting this done, I think has been a good success. We started an audit program. We started that about 2 or 3 years ago. And I'll just tell you that that has also been very helpful and has increased the rigor of the approach. So what's new for the TSOG group for 2024? We've got several clinical trials that are open, including this phase 2 neoadjuvant trastuzumab deruxtecan for HER2 amplified or mutant non-small cell lung cancers. Jay Isbell is running that. That's approved. Funding is coming through AstraZeneca and Daiichi. And I think this would be a small trial. This is not a common mutation, but looking at it in the neoadjuvant space. And again, an opportunity for TSOG to lead in conjunction with industry. Another study, Paula Ugaldi from the Brigham. I think you know her well. She has an interesting idea trying to maximize the number of N1 nodes that are positive on a surgeon/pro sector evaluation of the resected specimen to try to more accurately stage the tumors. This is a segmentectomy. We're opening a segmentectomy registry trial for non-small cell lung cancer resection. So kind of a real world outcomes led by Alper Toker and Scott Swanson. Alper from WVU and Scott obviously from the Brigham. And I would go back and just say that that trial is the first trial where we have wanted to collaborate with another thoracic surgery group, and the European Society of Thoracic Surgeons is going to open this trial in Europe as well. This is a phase 3 trial that we are leading through in North America through TSOG of 35 sites run through AstraZeneca, looking at a combination of a antibody drug conjugate with a PD-1 TIGIT bispecific checkpoint inhibitor versus standard of care. And this is an adjuvant trial in patients who have a high risk for recurrence after resection of early stage, meaning stage 1 disease. And then a multi-center trial looking at either radiation as a immune sensitizing checkpoint inhibitor sensitizing agent or chemotherapy, building off the work from Nasser's study that will open that. So at least 5 trials that are now opening in 24 that are multi-modality. And I would just say this is a paper that's in press at JTCVS, but this is some of the work that we did looking at high-risk patients for the AstraZeneca trial, the TL12 trial. Almost 2,000 patients with stage 1 lung adenocarcinoma. We had a lot of data. We could inform the decision-making on how do we classify which patient is actually high risk. And you can see if you look at SUV max or high-grade tumors by ISLAC grading criteria, LVI or VPI, simple things. The risks become, if you have more than 2 or 3 of these, the risk of having recurrence even for stage 1 lung cancer is like 30%. So by us contributing this type of information, it helped inform the subsequent design and what criteria are going to be used in that trial. And so that's just another example, I think, of how we can help. This is the trial schema. No reason to really go over that in any detail. This is the trial that Nasser has proposed. Again, patients with surgical disease, clinical stage 1B to 3. No ALK or EGFR, they're going to get chemo plus cemiplimab or cemiplimab and SBRT at 8, and looking at, again, a primary endpoint of complete pathologic response with the secondary endpoints below. Probably about 80 patients all in this phase 2 trial. Lastly, I'll close. If you remember, I think the real opportunities are going to be to find ways to do these trials internationally, which is what industry does as well. But I think there are opportunities for TSOG to collaborate internationally. At Memorial, we've spent the last 6 years building a very good relationship with CTONG. And I think this is all through relationships we've built with Yilong Wu from from Guangzhou. The Cetong portfolio, 46 Cetong members. These are all very tertiary referral hospitals. 56 principal investigators. You can see they're from medical oncologists, surgeons, and radiation oncologists as well. And you can see some of the publications. Most of you, at least in my field, will recognize these publications, many of which are practice changing, all coming through Cetong investigators and this consortium. You know, they've had a tumor board since 2021. It originates, as you can see in these pictures, from Guangzhou, and it's sent out to all of China. They have a monthly tumor or clinical trial meeting. I just put this slide in mainly because I just am amazed that the average online attendance is 30 to 40,000 physicians are thinking about, or at least being exposed to clinical trials. We have nothing even to compare to that in North America, but these folks are serious, and turns out there's a lot of patients in China. So we've had multiple meetings. We usually alternate between Guangzhou and between in New York City. I put the red circle there between myself, Bob Lee, who is one of our medical oncologists, who is Chinese, but educated in Australia and is on the faculty at Memorial, and then Yilong Wu, and we've really been able to build a nice relationship. This is a white paper that I would encourage you to read that was written by Bob and Yilong Wu, thinking about how are we going to do clinical trials after the pandemic. And it's really a patient-centered approach, and it really emphasizes how, with correct people on the bus, meaning Bloomberg, other heavy hitters, we can actually do these trials between North America and even China, even with the tricky relationship that our governments are having. And so we're going to have the next Guangzhou meeting where we're going to introduce some trial concepts that maybe not ACOSOG, but TSOG and Cetong can do together, and that's in Guangzhou, and you're all invited to go to that if you have any interest. So there are some challenges for TSOG. Clinical trial coordinator support is highly variable. I thought everyone had a clinical trial coordinator, but you don't. It's hard, and it costs money, and the institutions have to pay for that. You really need a site champion. Some people have just joined, but they haven't really put people on trial, and that's we know that's going to happen, but you need a champion there to try to get people on trials. The financial support, tricky, but getting better. Why? Because we're partnering with industry who can give us some support for at least on a per patient basis for accrual. I think we're trying to find a balance as a group without a lot of money into relative registry trials, which are simple to do. There are some investigator-initiated trials that we've leveraged from R01 funds to do that, and then the industry-supported trials. I think the coordinating center, we've now up to 2 full-time individuals. We probably could use 3, but I'm paying for that from funds I have, but that's not a small amount of money if you look at it. We open up all these trials, but individual sites are only going to open up a few trials. They can't open all trials. It's too much. So we have to be a little thoughtful about not overburdening people or expecting them to do more than they could. And we need more people to get interested in clinical trials, and specifically thoracic surgeons. This is the executive committee. I chaired it, still chair it. Ara Vaporsian from MD Anderson, Rafe Bueno from Brigham and Women, and then David Harpole from Duke. Alan Vincent, Marie Singh, and Aaron Carroll are the core group at the coordinating center who've done a huge amount of work. So I think, there's no incentive for surgeon involvement in clinical trial development or accrual. I think, I've incentivized that. I rolled out a compensation program 3 years ago, and faculty are incentivized to accrue patients to clinical trials, like monetarily incentivized. I think there's few surgeon role models who have a lot of expertise in clinical trials, but if you're a resident or you're a junior faculty, this is a great place to build a career in clinical trial, working collaboratively with industry or with other investigators. I think it's fantastic. The educational issues we talked a little bit about. I think funding for investigator-initiated trials, which is really something that we all like to do, is limited to, you got to have some philanthropy to do it. Sometimes industry will help you, but rarely are you going to get federal funding helping for this. So it's still a major issue. I think the institutional support, particularly for thoracic surgeons, where the institution just wants you to do cases, is challenging. So I think you got to talk to your chair. You have to make the case. This is important. It's the right thing for patients. And hopefully they can begin to carve out some money to get you a clinical trial coordinator if you don't have one. I think this engagement with pharma, it has to be above board. It cannot be anything shady or not ethically sound, but we need to have a relationship with them. It can be done well, and you have to just engage. And I think international partnerships with like-minded cooperative groups really is the way forward, even with all the challenges of distance and federal governments. So with that, I'll close and thank you again for the opportunity to be with you today, and happy to answer any questions.
Outstanding, inspiring talk. It's really nice to see that we need to get surgeons not only at the table, but also you've shown that we can be in the driver's seat as well.
You can drive.
And that's outstanding. Any comments or questions? Vice Sir?
Thanks so much, Dr. for coming and explaining this to us. I think it's amazing to add in the space and but whatever we discussed, your and others, and some of your thoughts. I know myself, I was extremely lucky to come to a place where there was no medical oncologist who really wanted to lead surgical trials. And so it was a power vacuum that I fell into. That is not the case in most places around the world. So how do you propose that the thoracic surgeons interface with their medical oncology colleagues, who are usually the point people for all these trials, to get leadership opportunities, to get authorship opportunities? How do you suggest we navigate that?
Yeah, I think it's a tricky point, but that gets back to relationships too. I mean, at some level, all politics are local, so you've got to locally have a relationship where you're hopefully collaborating with the medical oncologist or radiation oncologist. I think the other thing though is that, if pharma understands that, at least for adjuvant trials and for certainly neoadjuvant trials too, that in the early stage space, that they're going to have to engage surgeons. I mean, there's just no way around it. And so if they can identify individuals or institutions or groups who I think are willing to work and be collaborative, I think they're driving a little bit of who's getting involved as well. It's not just that we have to do it at our own institutions. I think the issue of the Europeans, it's tricky getting a clinical trial over to Europe, I'm finding out. So even this registry trial of looking at segmentectomies, which the ESTS is going to do, they're probably going to open it up. I talked to Isabel Oppitz, it's probably in like 4 or 5 centers, and get their feet wet, dip a toe in the water and see how things go. But I also think that's something that for the ESTS and the AATS or STS to work together would be fantastic. I just think Europe's going to be a little trickier because it's Europe's multiple countries, so it's not so easy.
David, thank you for presenting this very thought-provoking conversation. There's nothing more disappointing for me to see that a trial gets started, and we know how much effort is needed to achieve that. And then the trial closes 10 years later due to lack of accrual. And in surgery, the culprit is often the surgeon themselves. Lack of interest, they don't think about it in their busy clinics to enroll the patients. I see it in my institution all the time. And I've been victim of a couple of trials like this. What is the solution to that? Now, let me tell you something. I may have a solution for it, but it may not be a popular solution. I compare notes with my cousin, Roxana Miron, who works across the street from you. She's a cardiologist. Every time they come with a new stent, within a year, they have a trial with 10,000 patients in it, within a year. How do they accomplish this? Money. They go and they give to whoever wants to participate. Lately, it's about $10,000. They show up to the door of the institution. They'll tell you, for every patient you put on the trial, we'll give you $10,000. And within a year, they have thousands of patients on the trial, and they publish like this. It's incredible. And the advances science in their field, which is interventional cardiology, at the momentum rate that we are falling behind incredibly. So you were talking about the financial incentive to the surgeons, and I think this is key. It cannot be pro bono, just, recruiting the patient due to the, your pleasure or your kindness of soul or something like this. That doesn't work. We see it. So how are we going to fix that?
Well,
Comment or a question?
I think you did a good job of partially answering it, but I think at some point it takes institutional or departmental leadership to say, we are going to prioritize this. It's the right thing to do. And across your disease management team, where the surgeons are there, we're at tumor boards, but then we rush off to the operating room and we kind of let it all, we assume it's going to happen. But if surgeons want to be, as Dr. Spicer mentioned, on steering committees, they would like authorship on these very impactful papers, they have to be at the table, which means you've got to carve out some time. And that means that surgeon cannot be in the operating room at that point. They cannot be in clinic. And so everyone in your department doesn't have to be like that, but you need a few individuals who can be the champion. And it's nice if you have some luxury, whether it's philanthropy or institutional dollars, to compensate. I'm not saying I'm paying them tens of thousands of dollars like you are for each effort, but it's enough that they know that I think it's important. And so therefore they should think it's important.
I think really bang on about just in general trends of surgeons' involvement in science in many different levels. And this is one example where the incentives in the past haven't been lined up, but I think they need to be. And you've given some great examples of wonderful frameworks and models that you could use. One other issue that we see on the academic side is a lack of even academic credit for enrolling people on trials, even being site PI. How have centers addressed that in terms of currency, whether that's even in our model, it wouldn't be sort of a financial incentive, just in terms of payment schemes in general, but we're also challenged at the university level with how do we reward participation in trials for clinicians, and I don't know if you've seen any ways to address that.
No, it's so important what you talked about. I mean, we all want to be promoted. We want to be recognized for what we're doing from a scholarship perspective and from an academic perspective. I think the one good thing that I could say by creating this pseudo incentive plan is where I know how many people go on trial versus from each faculty member. So when I'm writing their letter now for promotion from assistant professor to associate professor, I put in the letter that, they've accrued this number, they're the surgical PI of this trial. So I emphasize it in the letter that goes to the promotion and tenure committee. So it's again a small thing, but the institution, P&T committees need to know that this individual is doing things that are really important for academic medicine besides just generating work RVUs.
You have a follow-up on that?
You want to answer the question?
My son is always saying he's 4. He says, I have a question. It inevitably turns out to be a comment. So I have a comment on the point of remuneration, maybe to raise this point. this per case funding for each accrual, there's usually a PI fee that comes with that. One of the challenges that I sort of foresaw in the establishment of our trials group is that medical oncologists are doing a lot of work for these perioperative trials. They're prescribing the medication, they're dealing with the adverse events. And so it was a problem, as I saw it, for me to take the PI fee in terms of their engagement. And there was competition with the rad oncs in terms of accrual for resectable and resectable. So we created a common fund. It's called the THORF, the Thoracic Research Fund. And all of our PI fees, whether it comes to the medical oncologist, the surgeon, or the rad onc, go into a common pool. None of us take any compensation for recruiting patients. And that's a common research fund that we use. I think that the offshoots of, like, in terms of financial gain, are in the ancillary things from being at the table with pharma, from having those discussions. And so it's really important to build these interdisciplinary groups that all have something to gain from the interaction. So, I mean, that's at least how we've done. I'm sure it's quite different in a place like this. So.
Yeah, I don't think everyone's as kind and thoughtful as you are in terms of sharing, at least in the United States. But I think that's a wonderful way that you got around it. And kudos to you for recognizing that it could be perceived as I'm getting all this money. That's good.
Comments or questions? I have one myself. You talked about the investigator-initiated trials, and you showed that through the thoracic surgery oncology, so you've been able to at least look at that. But to drive, I still don't understand where that money is coming from. Is it all philanthropy, or is it working on the machineries of each different institution, where they already have multiple trials that are industry sponsored, and they piggyback on that? Like, how are you getting these off the ground? We found that we had philanthropy for all our trials was the only way we can get the clinical research group, the clinical research associates and the data managers had to run by philanthropy, and then they piggybacked being able to run industry sponsored, but also do what we want to do with our own best initiatives. So it's all philanthropy. Another way to get access to money.
Yeah, it's the same. I mean, for us, if you do an investigator-initiated trial, you've got to have the philanthropy to get it started. You may be able to, if you're using a compound or a drug or something, that industry may supply that, or they may help a little bit financially, but I would say 90% of it's going to have to come from philanthropy. And we don't have any like just discretionary funds at Memorial, and certainly not through TSOG, to just say, look, you've got a good idea, we're going to give you $1 million to help you get your trial off the ground. It's all through philanthropy, which is a challenge.
Well, I'd like to thank you very much for coming to Montreal, and we're going to put you to work. So